at another case study here. This case study I'm going to call Another Monster. This is going to go on as a theme, and this is the initial x-ray. He's been a part of the practice on and off for the past 4 years. He has not been to the office in probably about 2.5. So the reason why I call it Another Monster is because there's so many of them out there that have these characteristics where they have a collapsed bite starting. So it's kind of an interesting thing. We're going to do follow-up cases with this one, and you'll want to keep track of this one because he only has one implant here, but I see a root canal treated tooth here and all the other kind of dentistry that he does. The other thing I don't have on my treatment assessment is tori. So whenever I see a lot of tori and I see this kind of collapsed bite starting, be forewarned that this person is going to be breaking their teeth quite a bit, and they don't necessarily like night guards, and if they do, they certainly don't wear them. And it becomes very challenging to keep dentistry working in their mouth. They also don't think it's them. That's the funny part about a lot of that, is they just think it's something wrong with the dentistry or something else. I'm not really clear on it. Anyway, it's a mindset, and that's a difficult mindset to work with. So let's look at the treatment assessment real quick, and then we'll move on to the CT like we normally do, and I'll talk through the case and give you a little more ideas and insights. But definitely follow up. Look at our follow-up cases. This is going to be one of them. I'm going to talk more about his kind of path along the way here, and looking at just how this progresses over the past 4 or 5 years. So now, in our treatment assessment, he's pretty much green when it comes to bone quality and facial bone constriction and sinus bone, of course, and all these things. Those are all greens and light greens. But where he comes down with the oranges, he comes down with a repeatable bite, chew pattern, and failing front teeth. So those are the areas that are really the concerns here, not the quality of bone. The bone quality is amazing, so we'll take a look at that in just a second. So let's do that. Let's look at our CT. This is number 4. And if we look straight down that one, let's see, we're not on that area. Let's go back to that. But you can see the facial bone looks great here, no constriction. And this would be number 4 area. Lots of generous bone. And you can see the tori here having been developed across on the upper arch. Whenever you see that, you better well know that you're going to get an easy result out of this. You're going to have a really good tissue line. You're going to have scallop tissue. Typically they have thicker tissue. So this is a winner. So this is definitely a starter case. Perfect. Your sinus is plenty far away. I do believe I put an implant in, but I don't know if this is the right one, but let's just see what it is. Okay, so that looks fine. It's a premolar size, so yeah, 4.2 by 11.5. That's what it looks like on the pano view. You can kind of get that the way you need to get it. Let's say that's about what it would be, I guess. But here's on the bottom. If you look at the bottom here, we've got quite a bit of tori here going through here. Now this is where it really starts to should concern you, because this is what's going to be hammering your implant here. And if we look at the tori up here, look at that tori up here. Wow, that is on the upper lingual side of the arch. Look at how big it goes out here on the molar on the upper arch. That's a lot of bone. Look at that sticking out into the lingual side. Look at that on the facial side out here. That's just really thick stuff, really heavy, and it extends almost entirely through the whole arch, that real heavy cortical bone. That is just really something. Let's look at the lower arch actually too. That's got to be a lot of stuff going on. Look at that, right on that first molar here. We're going to go down. I would not be surprised if that was less than 10 years old. This root canal treated tooth, he's just going to crush it. He's going to crush it. So he's crushing his front teeth. Like I said, we're going to do a follow-up thing on this case because we want to see how dentistry survives. Not so much I care, just to look at implants here, but what I want to look at is the whole shtick, the whole thing, how this is going to perform, how this is going to work, how you're going to restore this person, how you're going to communicate with somebody, how. So it's always good to learn from other doctors if you're a doctor. And if you're a patient and you feel that you have this big bony stuff in your mouth, that's not normal. That's this monster kind of power that's creating that bone. Think of the tooth as a peg inside the bone. And unlike your muscle here where it's stretching like a bow and arrow, your bone, and your bone has to get stronger to deal with the muscle strength, a peg goes in, which is your tooth, and you're hitting on top and the bone just grows outwards. So it's common, but it's not exactly ideal. It means you're really putting a lot of force on your mouth, on your jawbone's getting really strong, and dentistry is only rated for a certain amount of strength. So you can overpower your own teeth, of course, over time, for sure, but you're certainly going to overpower dentistry. So you have to learn to kind of tune it down. I don't know how to create like a physical therapy type of program for somebody to kind of tune down their masseter muscle. That just is really, I don't know, it's going to require a lot of personal attention from the patient, say, to actually get that going in the right direction to tune down that kind of muscle and the power that you're putting into your bite and your and it's not necessarily chewing, it's just your grit, you're just the way your teeth come together, how much power you give, it just overwhelms the dentistry. So you got to overdo and over-engineer a lot of the projects. If you maybe even do a wider implant here, but that's not going to be the problem. This patient's going to have more problems with any other type of dentistry that you do, especially in the front. You're going to have to get a balanced occlusion, which he doesn't know where home is. His bite moves all around. It's all flat and occlusion. Once he starts wanting to fix these laterals or the centrals, you got to raise the bite, etc., etc., etc. So it's a lot of education for the patient to deal with, and also if they're not in pain, they don't feel like they need to do anything. And exactly what should you do and what the advice is really up to you, but and the patient obviously. But it is one of those things that I follow quite a bit, and I do see more and more problems occurring down the road for patients like this. So there you go. There you have it. That's a simple starter one, but it's going to become more and more complicated. So thanks for joining us. Thanks for joining me. Like us on Facebook and subscribe to us on YouTube.